is Cindy Escobar. I am from the Catholic University and I will talk about acalabrutinib in replace the chronic lymphocytic leukemia. First, the definition. The chronic lymphocytic leukemia is the most prevalent leukemia among the adults. Although the chemotherapy prolongs the durations of the remissions and overall survival amongst the most patients with the CLL replaced virtually always occurs. This has prompted aggressive discovery efforts for the new therapies in the CLL because the B cells receptor signaling is a driving factor for the CLL tumor cells survival. Proximal of the kidneys involved in the pathway has been the therapeutic targets. Bruton tyrosine the kidneys is immediately downstream of the B cell receptor and is essential for the activation of the several tumor cells survival pathway and relevant to the CLL.
Good morning. Good morning. My name is Dr. Tim Call. I'm one of the hematologists here at Mayo Clinic, Rochester, Minnesota. And I just wanted to spend the next few minutes describing a little bit about the disease chronic lymphocytic leukemia, which I specialize in along with several of my colleagues here. This is a disease that if you've been given this diagnosis or have someone who has had this diagnosis, the word leukemia, or as I call it, the L word, is one that's quite shocking. But we'll talk a little bit about it, and hopefully we can remove some of the fear that goes along with it. The most CLL, chronic lymphocytic leukemia, can also be called small lymphocytic lymphoma, one of the diseases that has two names. The World Health Organization classifies chronic lymphocytic leukemia and small lymphocytic lymphoma as the same disease. But it will sometimes create confusion unless you're aware of that. This is the most common lymphoid malignancy in North America, and it is one that we see on a regular basis. Now, the average age or the median age of diagnosis is in the mid to late 60s. There's a slight predominance of males versus females, but both sexes can be affected.
The application in the medicine. Acalabrutinib is a second-generation selective and universal inhibitor of the BTK that has improved the pharmacologic features, including the favorable plasma exposure, the rapid oral absorption, and a short half-life, and the absence of the reversal targets to alternative kines give the success of the ibrutinib in the treatment of the replacing the CLL. We sought to determine whether selective targeting of the BTK by acalabrutinib will be effective and is more measurable to be response and safety profile. The side effects represent the most common reasons that the patient discontinue the ibrutinib treatment.
Inside the hollow area of the bones is a spongy core called bone marrow. It is here that stem cells are produced. Stem cells are immature cells that can develop into components of blood. Red blood cells, which carry oxygen to the body, white blood cells or lymphocytes, which fight infection, and platelets, which helps blood to clot. Chronic lymphocytic leukemia, CLL, is a type of cancer in which the bone marrow produces too many lymphocytes. The term chronic means the cancer cells multiply slowly and the disease takes a long time to develop. In CLL, the lymphocytes produced are abnormal and are not able to fight infection. As the number of these abnormal lymphocytes increase in the blood and bone marrow, fewer healthy white blood cells, red blood cells, and platelets are produced. This can cause the symptoms of fatigue, recurring infection, anemia, and easy bruising. Chronic lymphocytic leukemia usually does not produce symptoms in the early stages. Treatment and prognosis depends on the stage and extent of the disease. Standard therapy includes watchful waiting, chemotherapy, radiation therapy, surgery, and monoclonal antibody therapy.
Okay, the proof. The laboratory showed those differences in function of the B cells receptor, with a signal in the primary CLL cells. In the kidney injections assay, the acalabrutinib was more selective by the BTK inhibitor than the ibrutinib. Acalabrutinib was rapidly absorbed and eliminated after the oral administration. The pharmacokinetic results showed that exposure to the acalabrutinib increased in a dose of the proportional manner, with no drugs accumulations, and peak plasma values occurred between the 0.6 and 1.1 hours. The cons. The long-term therapy with acalabrutinib has not been associated with any high-grade acute toxic effect, but the most events that were observed will the grade of the 1 or 2 drug resolving over time. The most common adverse events were the headache, diarrhea, increased weight, the pyrexia, and upper respiration, tract infections, and the severe diarrhea, rash, arterial myalgia, and bruising and bleeding events is occur is no more than the 2% of the patients.
Ibrutinib targets BTK, so it's a critical molecule in B cell receptor signaling, but it also targets several other tyrosine kinases, which are possibly related to some of the side effects seen with the drug. And the new drug is CP196 or acalabrutinib, is a more specific BTK, so it hits less of the other kinases, and it hits BTK harder. What we're seeing, we've had the phase 1 trial, which we've been participating in the UK and in Leeds. A very impressive response rates, with very few patients actually progressing on treatment. Less side effects, it would appear. There's no comparison.
Right now, all of the studies that we've been doing in CLL, both in the relapse refractory patient population and also upfront. The data that will be presented, the clinical data presented here will be the relapse refractory patients. And so far it doesn't seem to be that there's a specific subtype of patient that is more likely or less likely to respond, and response rates very high. But patients that have cytogenetic abnormalities like deletion 17p or an IgDH mutated disease, they mutated disease, they seem to be responding just as well. But that's definitely as we continue to treat more patients, as we get hundreds instead of we'll be able to really learn and see if there's a particular patient subgroup that's better treated.
The conclusion in this study, the selecting of the BTK inhibitor, the accountability has promised the safety and efficacy profiles in the patients with the phrase the COF, includes those with the chromosome of the 17p30.1 directions.
BTK inhibitors clearly are the drugs of the moment. Ibrutinib showing phenomenal response, and of course it's not a surprise if you've got one drug of a certain class, there are subsequent drugs of the same class coming.
There's data at ASH this year
with the Chinese BTK inhibitor
showing broadly the same activity. There's also the
first ever data from
an American BTK inhibitor,
an American BTK inhibitor,
Pharma's drug in the context of CLL, which looks phenomenal. And I've been involved in some of those trials,
and also been involved in the Japanese.
So there are a number of these drugs. The second generation ones, the next step from ibrutinib, all look similar. Whether they're better or not, it's difficult to say because it's relatively early. From what we've seen so far, they might have a slightly better side effect profile, less bruising and bleeding, maybe fewer cardiac events, but I think you've got to have patients on these drugs for longer before we can be
clear about that.
Thank you.